Okay, so let's set the scene. I want you to picture an operating room. It's this world of calm precision, full of quiet beeps and hums, where every single move is practiced. It's routine. It's a place where amazing things happen every single day, all built on this foundation of safety and total control.
But here's the thing. That control is balanced on a razor's edge, because when a patient is under anesthesia, even the most standard everyday procedure can flip into a full-blown emergency in, like, the blink of an eye. The line between routine and crisis, it's measured in heartbeats.
And the most fundamental crisis you can possibly have is centered on the one thing we all do without even thinking about it: breathing. So what happens when, in this super-controlled environment, a patient suddenly can't get oxygen?
So we're going to walk through one of the most feared scenarios in all of anesthesia, that very moment when a patient's breathing can no longer be controlled by the medical team.
Okay, so the official term for this problem is an unanticipated difficult intubation. Intubation, that's just the process of putting a breathing tube down the windpipe, right? It lets them deliver oxygen and anesthetic gas straight to the lungs. It's a cornerstone of what they do. A difficult intubation is when even a seasoned pro is really struggling to get that tube in place. Now, you'd think they could see this coming, right? And they try to. Anesthesiologists are trained to look for this stuff. They check every patient for signs of a difficult airway. Things like obesity, or if you can't open your mouth very wide, or you have limited neck movement. Even having big front teeth can be a red flag. They've got a whole system for it.
But here is the absolute kicker. Despite all those checks, all those scores, 50% of all difficult intubations are a complete surprise. They happen in people who had zero warning signs. The routine, in an instant, becomes the unthinkable.
And this is where we really have to reframe the entire problem. The emergency isn't failing to get a tube in. Nope, it's something way more fundamental than that. There's this quote in the anesthesia world that just says it all. The enemy isn't the failed procedure. The real enemy is the ticking clock of oxygen deprivation. The brain can only go for a few minutes without oxygen. So right then and there, the entire team's focus has to pivot.
So in a moment that could easily, and I mean easily, fall into complete chaos, it's met with rigid, practiced order. You see, the real hero of this story isn't a single person. It's a protocol, a very carefully designed algorithm that's taught to everyone from a group called the Difficult Airway Society.
The protocol kicks off with Plan A. These are the first attempts, but they're done with a very strict structure and, importantly, a clear limit on how many times you can try. Plan A allows for up to 3 structured attempts. And this is key. Between each try, they're giving the patient oxygen with a face mask to keep their levels up. The team might try repositioning the patient's head or use this special tool called a bougie. Think of it like a thin guide wire for the breathing tube. Or maybe they'll switch to a different kind of scope to get a better view. The point is, it's methodical, not frantic.
But that clock is always ticking. So, what happens if, after 3 calm, calculated attempts, the tube is still not in place?
This is where the mission officially changes. The goal of intubation is completely abandoned. The new priority, the only priority, is to oxygenate no matter what.
So the team immediately goes for backup devices, like the laryngeal mask airway, or LMA. Now, the cool thing about an LMA is that it doesn't have to go all the way into the windpipe. It just sits right on top of the voice box, which makes it way faster and easier to place in an emergency.
And this right here perfectly shows that shift in thinking. Every single person in that room knows this is the new goal. The elegance of a perfectly placed tube? Totally irrelevant. The only thing in the entire world that matters is getting oxygen from the machine into that patient's blood.
But what if even that fails? What if the patient's airway is so swollen or blocked that you can't get the tube in, and you also can't force oxygen in with a mask or an LMA? This is it. This is the ultimate nightmare scenario. Can't intubate, can't ventilate.
When every other option is off the table, the protocol has one final decisive step: Plan D. It has a big, scary name, a cricothyroidotomy, but what it really is an emergency surgical airway. They call it a front-of-neck access procedure. Basically, it means they're going to bypass the mouth and throat entirely and create a direct opening into the windpipe from the outside of the neck.
And this procedure is unbelievably fast. The doctor finds a little soft spot in the neck, just below the Adam's apple, makes a quick incision, and puts a breathing tube directly into the trachea. And just like that, oxygen is restored. The patient's life is saved. It's a drastic move for sure, but it's the definitive answer when you're in that can't intubate, can't ventilate crisis.
So what is it that turns this potential disaster into a managed event? It's not about getting lucky. It's all about the power of a plan.
And this is the most crucial takeaway. Modern patient safety isn't about some heroic doctor who just magically solves the problem. No way. It's about building a system, a protocol that a well-rehearsed team can execute perfectly, even under the most extreme pressure. I mean, the difference is just night and day. One path leads to chaos. It's reactive and it's incredibly high risk. But the protocol is structured. It's proactive. It completely transforms a moment of potential individual failure into an opportunity for team-based success. And that dramatically lowers the risk of something terrible happening.
And that really makes you think, doesn't it? From airline pilots running through emergency checklists to firefighters entering a burning building, this whole idea of replacing panic with a practiced protocol is what stands between us and disaster. It's a powerful reminder that the best way to handle the unthinkable is to have thought about it and planned for it long before it ever happens.